welcome back to another episode of Ask Your Doctors. I am Dr. K. I am actually Dr. Komesi Mukwili, aka Dr. K. And I am with none other than Dr. Mpume Zenda, aka Dr. Gynae. If you don't have an AKA, you can't be a doctor. Anyways, Doc, what's happening? Thank you for coming back.
It's always a pleasure. Thank you so much for having me, and your amazing crew is always on point.
Forget the crew. I'm the center of attention.
They make this happen.
Doc, just when we were going to ask you to come back again, this is the last time.
This is the last time.
But you are a woman of your words. You did come back.
Yes.
And how has your week been?
Amazing, actually. Had a bit of a rough beginning of the year, but things are starting to settle in. So,
cabbage in January is not rough.
I don't do cabbage.
It's just roughage.
I don't do cabbage in January, but everybody's medical aid has paid. So people are really keen on getting their checkups done, and they've forgotten about the festive season. They want to get back into healthy and having their gynae checks. So we've been quite busy.
Oh, that's nice.
Yeah.
And so we are fortunate to actually get you.
Absolutely.
I feel privileged. And please don't lose that touch. Now, Doc, today we're talking endometriosis.
Right.
As a very topical topic,
right,
as well as many other, one or two other complications of the reproductive system,
right,
as it pertains to February and its reproductive it's a month of reproductive health education, isn't it?
Right.
Yeah. So now, can you tell us what is endometriosis?
Right. So endometriosis is when inside the womb there is what you call the endometrial lining. So the cells or a little bit of that tissue, it can actually go retrograde or and end up growing inside someone's stomach.
Okay.
And so because of the nature of that tissue, when a woman is close or just before their period and they have a let me call it a neurotransmitter called prostaglandin, it causes the womb to contract. Now, that's what gives most of us women period pains, which are easily treated very often. But in endometriosis, all this tissue that is sitting, it could be inside the stomach. Sometimes it may even go outside on the cervix itself, on the vagina. That same tissue will do exactly what the womb is doing and cause pain that is excruciating in other areas as well. And it can be quite a debilitating illness.
So endometriosis is overgrowth of the lining of the...
Yes, where it shouldn't be.
Yes.
Yeah.
Oh, all
Yeah.
right. Now I see, okay. And because it consists of the same smooth muscles as those of the womb,
yeah,
when the womb contracts, it will contract wherever it is.
It causes that discomfort of pain as well, yes.
Never overgrowth, anything like that?
Oh yeah, it does overgrow, and it's not just the overgrowth, it's also the how it affects the rest of the organs inside, and that's where the majority of the conflict, it encroaches. That's why people will experience things like bloatedness, because if it's in the intestines, you get the meshing, or what we call in our medical language adhesion. So everything inside the stomach gets adhered to the womb, the ovaries. You can also get things like what we call a chocolate cyst or hemorrhagic cyst, and that can have a great impact on the functioning of both the ovaries and the fallopian tubes. So this will result with somebody complaining of things like struggling or having difficulty in conception. So it's not just the pain, it is also the difficulty with conception. It is the chronic pain that may lead to, so it causes a vicious cycle in mental health. A lot of people with endometriosis will have either depression or anxiety, and it's a vicious cycle. When I know that my period is approaching and I'm going to be in pain, it is a financial situation as well, because they generally either have to be attending a lot of doctor appointments, surgical intervention, but also the cost of paying for pain medication, the cost of being away from work, that impacts. And then last but probably one of the most important, it affects the relationship because they generally have sexual pain as well. So sex during pain, deep pain during sex. So they will start avoiding being intimate. That will be interpreted, especially if the partner doesn't understand what's happening or both of them are not well educated about the condition. It can cause a lot of problems in their sexual health in the relationship.
I'm going to ask you how common it is and why necessarily we should be talking about it now.
Right.
But you speak of pain and obviously the format now of our production is that we will have one question from the crew.
Oh yeah.
They're talking about mood swings.
Yes.
And does it cause mood swings, and does it, you have already said it affects sexual relationships between partners.
Right.
Fine. And it affects conception.
Right.
And it's debilitating.
Right.
Mood swings, do they creep in there?
I think it's important. I wouldn't say it directly causes mood swings, but if you think of the woman's cycle, we are cyclical beings. That means just before the period, we go through at least about 60 to 70% women will have about what we call premenstrual syndrome, which is associated with either emotional and psychological features as well as actual physical features. So part of that PMS syndrome is somebody may be moody, they may be depressed, they may have anxiety, they may be more angry, more irritable around that time. Now, endometriosis, in terms of how do you separate someone who's just got normal period pains versus someone with endometriosis? The endometriosis, the cardinal thing about it is that it goes on, the pain occurs before the period, during the period, and sometimes can even last after the period. Also, with the increase of the staging of the endometriosis, you may actually find someone experiencing pain literally around their cycle, particularly stage 3 and stage 4, where you've got adhesions, you've got cysts, you've got deep endometriosis within what you call the pouch of Douglas in the uterosacral areas, which may be exacerbated, as we have spoken, by things like intercourse.
How common is it?
1 in 10 women, so about 10% in terms of globally. So it is a relatively big number of women who experience this. And I think the reason it's so important to have the conversation is that for the longest time, women grow up thinking having pain is normal. So it is downplayed. It is not. A lot of people with endometriosis actually get diagnosed very early. I mean, very late, so to say. They keep going back and forth to doctors and they get dismissed or they get treated with some analgesia or pain medication, and it's not taken seriously. And there is this notion from way back in centuries where it's just considered that women they always complain, so it's overlooked, it's dismissed, and so people don't often get the necessary help quite immediately as they need it.
Another old wives' tale about endometriosis: does pregnancy improve your situation? Does it get rid of endometriosis? Does it make it better? Or?
Right. So pregnancy does, and that you'll also understand the reason we use certain medication that stop ovulation, because ovulation is the cardinal cascade to that prostaglandin, to that causing of the contraction, which then subsequently causes pain. So when someone is pregnant, they don't ovulate. So for that 9 months, they can most likely be, in fact, endometriosis is thought to be suppressed during pregnancy. It's in the same light that any contraceptive that causes suppression of ovulation is seen to be helpful in someone with endometriosis.
So likelihood is that you can suppress it for 9 months, and if you don't have other means of dealing with it, it might come back again.
It never goes away. That's the reality of it.
What causes it? I mean, I know we are right in the middle of this, but the incidence and the why would some people have it, some people not have it?
So there is it's the theories and any research and textbooks that you would look at the moment, it still speculates that all these are the theories. The one is, as we've spoken about, is what you call the retrograde, or the moving back of those cells from the uterus itself back through the tubes into the stomach. But there are things like, for example, embryonic. So in the conception of a child, where these tissues that are supposed to be in the uterus, they land up somewhere else, and that can be the cause. There is definitely a huge, also a hereditary or a family history, where if you have it in the family, it is likely to be genetically passed on. So those are all some of the theories that are there to suggest where does it come from and who is at risk.
So how does Mbali living in Alex or in Kwakwa differentiate between period pains? And I know you said it might continue beyond, but what's the most practical clinical signs and symptoms that they should pick up? I know clinical signs are picked up by you, the symptoms are picked up by the patient.
Look, for the patient, I always say, if you have period pains that are not treatable, or that don't get better with what we call simple analgesics. So things like, I don't want to mention actual brands, but anti-inflammatories, just your normal period pains. And also, generally for the non-endometriosis period pain, is that as soon as somebody starts their period, it actually gets better. Whereas in endometriosis, not really, they will continue to have the pain generally throughout the period itself. The other important factor is, any time that a condition or this kind of pain is impacting on your quality of life, your ability to attend school if you are still in your school going age, or affect you going from work, people who literally have to be booked off during that time, that is really an important red flag for you to go and have it checked out. From our side, and we can speculate all we want, the final diagnosis has to be made by putting in a camera inside and looking and seeing if there is endometriosis.
And target group, who should watch out?
I think any woman of reproductive age, particularly if they are being bugged by period pains quite significantly. The earlier, the better, you know.
Because it spreads.
Because it spreads and it gets worse. And if it is, we know that we can't completely eradicate it, but if we can target in preventing the complications, getting the person the medication early, because it's not just about managing the pain, which is what the patient will complain about, but it's thinking about if someone is still in their teenagers, for example, they may not necessarily be thinking about pregnancy, but we know as clinicians that if we don't do something and treat it and manage it properly at an early stage, later on it may progress into issues where their fertility is affected.
And now I spoke about someone who lives in the township, rural areas, whatever. I mean, I'm talking about socioeconomic means.
Right.
Because it's so common, what are the dynamics of assistance, diagnosis, and management that we have in the public health system? Just briefly, in your opinion.
When it comes to that kind of condition, endometriosis, we have everything that is necessary. Of course, our system is classified depending on the levels of care. So what becomes important is the chain of referral. If as a nurse at a clinic, you've seen this lady who is 21 years of age and she comes almost every single time because of her periods, that should give you some kind of a red flag. It's not your responsibility to diagnose endometriosis, but send them to a higher level of care where they may possibly be seen by the doctor. They may be seen by someone junior, perhaps, you know, an intern, a medical officer, a ComServe. That's fine. That doctor themselves must be able to have a referral entity in them to say, okay, this is a little bit much. I've given everything that I can within my scope. Maybe this woman actually does need to have a laparoscopic procedure done so that we can see. Then, and in public, in state, there are specialists there. There are gynaes, there are registrars, which are a specialist in training when it comes to obstetrics and gynecology. And these procedures are readily available. That's where we all learn how to become great gynaes and obstetricians, hopefully one day.
Yeah, no. Really hectic, Doc. And some of our Facebook questions have already been answered.
Sure.
It's about period pains and how they relate to endometriosis. Some are about mood swings.
Yes, yes.
So we let's just look for more of our questions because we don't want to
repeat.
And then we also asked the one about contraceptives having an impact on endometriosis. Does it make it go away? You said some suppress it a bit. It
suppresses. So endometriosis doesn't ever go away. It gets better with certain medication, with certain stages of life, like pregnancy and very often after menopause as well, when you're not ovulating anymore. It gets better, but it never goes away.
Not even menopause takes it away.
No, but if you like I said, if you think about the fact that it is as a result of that cascade of ovulation, we don't ovulate after menopause. Once you've reached menopause, there's no ovulation anymore. There's no periods anymore. So generally, you'll find that people at that stage, in fact, even earlier sometimes, if they've been affected quite gravely, they will go right ahead and remove their uterus as a measure to curb the.
Does that help?
Oh yeah. Oh yeah, if the right person is doing the hysterectomy, because the important part is to be able to remove it from a point where those endometriosis tissues are sitting deep down. Yeah. So if they know what they're doing, absolutely yes, it goes a long way. Yeah.
Yeah, because I've heard a lot of, hysterectomies, which is the removal of the uterus,
yes.
Is it?
Yeah.
Yeah, it is a common procedure that's performed a lot in the modern world, and you would ask yourself, why so drastic?
Yeah.
So why so hectic? Why don't you? Why the resective surgery cannot be selective?
Right.
But I suppose anyone with that kind of pain would say, take my whole stomach away.
Absolutely.
No, and then other management modalities. Right.
So the management modality, we often match it quite closely with the symptoms that the patient presents with. For example, you get the so-called conservative. The nice thing about when we want to diagnose endometriosis is that when you do that, which is via laparoscopic, it can be a dual, you hit two birds with one stone. It is both diagnostic, so you see that there is endometriosis tissue, but also you can then burn the endometriotic tissues, which is part of the treatment. Things that before maybe you get there, you may have tried contraceptive intrauterine devices, the hormonal ones, they can be quite helpful. You do get particular contraceptives that have been designed because of the type of progestin that is put there that helps a lot with the endometriosis. And then, like we said, so that would be the surgical, which is the burning, but also even extensive surgery like the removal of the uterus when it is deemed necessary. The other adjunct treatments have to do with things like, for example, someone experiencing infertility. So this might be a person who may need to have assisted reproductive procedures like the IVFs if the tubes have been damaged from the endometriosis. So those are some of the scope of medicals and surgical, but also what we often don't say a lot to our clients is lifestyle.
I was about to ask because
lifestyle
it's the next question.
Yeah, lifestyle.
Why are you looking into my stuff?
Not even. Yes, I'm born.
Okay, I need this job, right? So stick to what you do. I'll do what I do. Right. Lifestyle. How does it affect?
Right. So endometriosis is an inflammatory process. It's an inflammatory. So anything that raises your inflammatory markers. So in terms of food, alcohol, caffeine, sugar it exacerbates that inflammatory process. And I'll even go as far as saying, you know, these are probably the women who do need the so-called period leave, rest, because stress, it exacerbates that inflammatory process. Find ways to rest. Eat well. That goes a long way. Drink plenty of fluids. Weight will always be an issue. And I think pain has this knack of interfering a lot with your mental well-being. When you are in pain, you don't feel well. So the intervention from the psychologist and particularly the sexual health trained ones. Sexual well-being is another one. Educate the partner so that they know the kind of intercourse, the best times to have intercourse as well goes a mighty long way.
Thanks, Doc. Very insightful. Right now, we would like to go viral with Dr. Bonolo Mashishi. Let's not get depressed. Omicron was very prevalent, very virulent, but I'm not sure if we should be taking any comfort in that. It's possible that the fifth wave might be just as mild as a normal flu, but that doesn't mean you must stop social distancing and washing your hands. Wearing of masks, we gotta do what we gotta do. Let's go viral with Dr. Bonolo Mashishi.
I think people should rest assured and know that COVID is not a sexually transmitted disease, so you can't get it from having sexual interactions with your partner. But what is important to remember is because sex is such an intimate act and you're in very close contact with your partner, you can still get COVID during this act, not necessarily because of, you know, the virus being transmitted through semen, etc., but because, you know, you are kissing and the virus is spread through the air, and that close contact can encourage spread of COVID. Also, we have found the virus in feces. So if you are engaging in sexual behaviors around the anus, anal sex, that may also potentially be a risk for contracting COVID. But before we get there, just want to know exactly what you mentioned earlier, that you guys do calls, you get emergencies. What are the typical calls and emergencies that you get in ENT?
So you're thinking ENT, it's all about orifices, like you have mouth, nose, and ear. The most common calls we get is any form of obstruction. Form of obstruction can be in a form of foreign body. A child's putting a battery in the nose or battery in the ear, or a bead. You know, you're untying a little girl's hair, you turn around, they put a bead in the ear or in the nose. Or it could be mostly more systemic, whereby there's an inflammation or a tumor. So that tumor has now gone so big that it's blocking your airway and you can't breathe.
Welcome back. Thank you very much, Dr. Mashishi. Guys, we wouldn't let Dr. Gynae go without going through a few critical aspects of this. Number one, a question from the crew again. I think they're abusing this, but it's critical.
Right.
You mentioned something about there might be appropriate times, there might be strategic times to have intercourse in the advent of one of the partners being an endometriosis patient.
Right.
Okay, she's not a patient in the house anyway. But any more light on that?
So we spoke, I think, probably in a previous episode about the cyclical nature of a woman. When a woman is...
And again, the crew was busy fiddling with this.
The crew is speaking for the people. So when a woman is going through ovulation, it's not just the fact that she is most fertile, but her sex drive is high because of the estrogen that's increased. Her testosterone is also at its best around that time. And so pain is experienced a little bit less. Her mood is better. It's the time I always say women want to be on top when they are ovulating.
The lioness roars.
Totally. Be careful, Mr. Crew. You were wondering when you are likely to fall pregnant, it's also still the time where you're still most likely to fall pregnant. Versus around the PMS phase where the mood is down, the estrogen is down, pain receptors are more felt, her mood is already irritable, and so it is also more important to use more lube around this time. Be more patient, be more, even just things like general breast tenderness is more prime around the time of premenstrual, which is just before the period. So it's not that you can't have intercourse, it's just you have to be a little bit more cautious. And I always say, allow her to take the lead, because she will be able to tell you what is painful
so it's
and what
Valentine's
isn't.
Day all over again.
It's always Valentine's Day.
Whatever, it's fine. Okay. I think this episode has been long. Let's talk about the steaming.
You mean Yoni steaming?
Doc, educate me. Okay, I'm the conduit. Educate the public.
Right. So there's this big trend at the moment that is quite big, which is, I mean, I just think of it as it's steaming the vagina. Yes, there are a lot of ways that people have, whether it's herbs and so on, but I think what we have always been cautious about is it medically sound? Is there any research that supports that this practice is really, it works? At best, anything when you steaming, whether it's whether you're taking a shower or a bath, that the heat, it does improve circulation. Okay. Circulation improves the experience of pain. That's why during period pains, or even in someone with endometriosis, we'll encourage them to use things like hot water bottles, yeah, because that it helps in the experience.
I have a 14-year-old daughter. Water
Right.
bottle, yeah.
But I think it is misguided for us to say that things like Yoni steamings take the place of people not going to have their regular checkups. That it is it treats conditions like fibroids and endometriosis, because we've seen this all over the whether it's social media or any kind of media actually. And again, I often say how do you know that something is sound? I always say, look at who's giving the information, and can you hold that person accountable should things go wrong? As doctors, you would know, we have to subscribe by a certain ethics, and if we transgress those, whether it's in what we say or what we do, we have to account for that, and patients can actually sue us. So whoever is selling you stuff, ask yourself, am I able to hold this person accountable should things go wrong? And I think just last but not least, remember the vagina is not supposed to smell like roses. It's not meant to be it's normal for us to experience a discharge. So don't be fooled by all these things that promise freshness, organic, and you will smell like pineapples. It's like,
yeah, let's not overdo things.
No.
So normal steaming that's not supported by too much scientific evidence, what's safe? I'm not saying you advocate for it, but I'm just saying,
if it makes you feel good, go for it. For me, it's just as good as taking
2 minutes, like noodles.
I wouldn't even put it there. Take a shower, take a bath. Why are we steaming? You know what the other problem is? When you start saying how long you should be steaming, remember, and I always make this example of when the trend of, brows on fleek. Some went and shaved them off and drew them. So every single woman from all walks of life, you can't assume they will do it in the most safe of way. People have risk of burning yourself, a risk of actually causing the pH to shift, which then predisposes you to more serious sexually transmitted infections, as well as things like the yeast infection and UTIs. So, no.
My advice to the public regarding hacks that we get on the internet, and on obviously mostly internet-based hacks, is that do not read one article and practice everything that you find in there, or at least go home and keep a huge argument about one article that you read. Read 2, 3 opposing articles, and still have conversations about it.
Absolutely.
And then ask your doctor if you want.
Yeah.
You see what I did there?
Yeah.
Yeah. So
you just marketed yourself.
Yeah. Look, go and go. go and ask your doctor, I read about this.
Yes,
No
absolutely.
offense, but I would like you to unpack it for me.
Yeah.
That's what the consultation is about.
Absolutely.
Yeah, no.
And as doctors, if we are not part of the conversation,
Yeah.
we are then letting our people down, because we are then not giving facts that actually empower them so that they practice izinto right.
Doc, February, the month of love with you, has been quite a ride. And it's okay, things have to end. What goes up must come down. And now, Doc, please tell our viewers,
Yes.
and I know you do a lot of work on your page.
Yes.
If anyone really wants to, they can go back.
Yeah.
There's reels and there's videos and there's whatever. There's advice, plenty of advice on your social media pages. Please tell them how to get there.
Right, our social media page, Instagram and Facebook at the moment, it is dr.gynae. And if you are keen for a consult, you can even go on our DMs and you'll find the information, our telephone numbers for our office, as well as our email address. Otherwise, you will find us at Morningside Mediclinic in Sandton.
And you can also find Dr. Gynae on our website.
Yes.
All our experts' details are saved safely on our website. Please go to www.askyourdoctors.co.za and click where it says find your doctor. It's been nice having you. I hope you will be able to watch again next week as we talk about more things medical. Please don't forget to go straight to our social media pages, load your questions, because who knows, your question might be the one we're asking next week. Until then, ask away.
Yeah.
Thank you, Doc.
Always a pleasure.